Good evening, all. That my screen is visible. Am I audible? Am I audible?
Yes, sir, audible.
My screen is visible. Screen is visible. It's changing. Slides are changing. Yeah. Today we'll start the session about ABG analysis. I'll make it little simple what I understood about ABG, and I'm not going to talk about extraordinary things of ABG. If you want a lot of resources, I can share in the groups, but I just want to focus mainly on how simplified you need to analyze the ABG and how useful it is. So that much only we'll talk today. What are the components of ABG? Whenever you see ABG, what are the all things you need to look for? It should be interactive. It cannot be like a lecture. pH, PCO2, bicarb, PO2, yeah, that's all. So what are the modern ABG should show you now? Yeah, base excess, hemoglobin, lactate, yes. Anything else? Electrolytes, yes. With hemoglobin, yes. Anything related to oxygen? Yeah, PO2, apart from PO2. Yeah, SaO2. Fine. So one is pH, it is a measured acid-base balance of your blood. And PaO2, it is a partial pressure function in arterial blood. And PCO2, it's the carbon dioxide partial pressure in the arterial blood. So these are the three things actually we'll measure directly. And bicarb, it's a calculated value. So we cannot directly measure what is bicarb in ABG machine. So it will derive based on pH and PaCO2 using what equation? So what equation it is going to use to measure bicarb based on pH and PaCO2? So the commonest equation we all be reading from MBBS. Yeah, Anderson-Hasselbalch equation. It's a derived one actually. It is not the actual one we'll measure here. Based on this bicarb, we'll calculate the base excess or base deficit, relative excess or deficit of base in the arterial blood, and oxygen saturation. How much is the oxygen saturation? So actually, it can be two. It can be calculated or it can be directly measured by co-oximetry. Some of the new modern ABG machines directly has co-oximetry. So they can measure directly SaO2, methemoglobin levels, hemoglobin levels based on this co-oximetry thing. So you can see here, they divided into the components into many subgroups here. So the first three are actually the measurable values: pH, PCO2, and O2. It's directly the function of the ABG machine. Four are oximetry values. If ABG machine has oximetry, even this can be measured values. You can see here SO2, hemoglobin, and fetal methemoglobin. Are three components which will come by oximetry. Metabolites like lactate and glucose also sometimes you can get. This all depends on how much combinations you're asking for the provider. And this is the last subgroup you can see here. Your bicarb, base excess, base, all these are calculated values. These are based on the function of pH and PCO2. and based on the equation of Anderson-Hasselbalch equation. So my question here is, what bicarb we're going to consider when calculating like bicarb corrections or anion gap? So what is the bicarb you want to take here? You have two values here. One is the patient value, one is the standard value. So what bicarb we need to consider for calculations? Patient. Okay. Any other answer? So someone is disturbing. Can you mute yourself? Participant. Sai Kishore. Can you mute? Sai Kishore, can you mute yourself? Yeah. Standard. So how many of you say standard? How many of you say it's patient? If anyone telling standard or patient, you need to answer what is standard. What is meant by standard? What is the difference between standard and patient? Corrected to temperature, partially correct. One more component is there to correct. It's also for the normal CO2. So this is here the CO2. For this CO2, you have calculated the 21 is the patient value. And you need to optimize this bicarb to the normal CO2. If you have to think for PCO2, normal CO2 is 40. So you need to calculate the bicarb for that PCO2 40. So then it's the standard. It's like you need to optimize the CO2s and temperatures to get the standard value. So that's why you need to take the standard value for all the calculation for practical purposes. Always use standard values, not the patient values. Patient value depends on the patient's respiratory conditions. But standard value means you need to assume that respiratory conditions are not there. So that's why always use the standard values. So it is a true indicator of metabolic problems. And patient value can be modifiable by if there is a problem with the respiration. So when we want to how to analyze the ABG, the first thing you need to see is what is the source, because the source can make a difference in ABG. So whether it's a capillary source or venous source or arterial source, so you need to identify the source first. And what are the major differences between arterial sample and venous sample? Major difference. You have a like head to tail difference in ABG with from venous to arterial. Which component? Not PCO2 majorly. Yeah, PO2. So PO2 has a significant difference from arterial to venous sample. So pH will be lower in venous sample, and it's mainly because of the high CO2. And PO2 will be significantly lower, like the difference will be around 60 mmHg, and PO2 will be slightly higher in the venous sample. It's around 5 mmHg. So because of this 5 mmHg rise in CO2, your pH will be little lower. And lactate, so this will not major difference. The maximum lactate difference what they shown is like around 1. Maximum is 1. That is the difference between arterial and venous sample. So basically it's the O2. If you want to look for O2, you cannot do VBG. Like you want to look for the respiratory status of a child with ARDS. You want what is the oxygenation status of the lung. So you cannot do VBG. So, and one particular condition where you do VBG, basically from central line to know the oxygenation status. You don't want ABG at that point of time to see the oxygenation status. What is that condition? No, I'm talking about oxygenation status. The measurement of oxygen. That is PO2 and SaO2. So you need to see PO2 and SaO2 in venous sample in particular conditions. not as a respiratory condition. It's shock. Mixed venous saturation or central venous saturation, you look for to see how much the perfusion is affected. So we'll try to keep it around 70%. So anything less than 70% tells that your perfusion is compromised. You need to optimize your shock measures. So that is the only where venous oxygenation is very important for us. In rest of all conditions, if you want to look for oxygenation, it is ABG. You need to take from the artery, not from the venous. But rest of all components, metabolic acidosis, you can easily manage with venous samples, no need for arterial samples. So these are the normal values, pH anything between 7.35 to 7.45, CO2 35 to 45, average you take as 40, PO2 above 80, so oxygen saturation is above 95, bicarb like around 24, and base excess it should be in plus or minus 12. For our all calculations, take CO2 as 40, normal CO2, bicarb as 24. So for normal our calculation purposes. The next question is this ABG valid? So for that, you need to use your Henderson-Hasselbalch equation. So that is, you need to calculate the H plus. The formula is 24 into PaCO2 by bicarb. So if you have this inconsistent H plus to pH, then you need to see that this ABG is probably not valid. Don't think you need to calculate for all this. Just go down, just see this ABG and tell me is it valid or not. You don't need to actually calculate all these things. Just by seeing the ABG, you can tell whether it is valid or not. Is this pH, PCO2 and bicarb can coexist? What, man? No answer. Simple only, right? pH is less, your PCO2 is less, bicarb is high. How it is possible? So for that, you don't need to calculate all these things. Yeah, exactly. So this is the problem with the ABG. So some error has happened, so it's not a valid ABG. So, but this is like general practical purpose. You need to do objectively, you need to use this formula. So can someone calculate and tell me this? What is the H plus here? Take bicarb also 24. Don't need to worry. Take bicarb plus 24 and calculate and tell me. Yeah, very good. Someone 33.6. So now you go and see the table here. So for pH of 7.25, what is the H plus at the point? For pH of 7.25, what is the H plus you need there? So what is the H plus you got now? 33.6. So it is invalid. So this is the way you can, if you have a doubt, if you want to validate your ABG, you can use this formula and this table. Don't worry, I'm going to share this PPT in the group. So just concentrate on what I'm talking. So this is the way you need to validate your ABG. And the next thing you want to move is you need to see the pH and tell it is alkalosis or acidosis. So any pH less than 7.3 is acidosis. Any pH more than 7.4 is alkalosis. I know everyone is clear about this, so I want to not stress here. And you need to remember one point. Even if the pH is in normal range, you can have acidosis and alkalosis. Never ever see only pH and tell that ABG is normal. It's not like that. Even if pH is 7.4, the child can have acidosis and alkalosis. I'm giving an example down. So can you tell me what, can you interpret and tell me what is the ABG is? Is it normal ABG or abnormal ABG? pH is normal. So there is no acid-base imbalance here. Yeah. So what problem you have here? Acidosis. What type of acidosis? Respiratory or metabolic?
Respiratory alkalosis and metabolic space.
Yeah, I'll come back to your group. Okay, you identified there's a problem. There's a problem with respiratory as well as metabolic, but it's mainly metabolic acidosis. Why you are talking as metabolic acidosis will be. We'll see in the next slides. So I hope I'm clear. So never see pH and stop there. So that's the first thing you need to learn from today's class. Because I have seen this kind of mistakes happen and missing metabolic acidosis because the pH is normal, because the patient is compensated well, and we missed RTS as well, renal tubular acidosis. So never ever just see pH. If it is normal, just stop the reading ABG. No, you need to look at CO2 and bicarb. Even if they are in normal range, then only you can tell the ABG is normal. If they are not in normal range, ABG is not normal. You need to tell whether acidosis or alkalosis is there, definitely. So I hope I'm clear what I'm talking. Never stop at pH. Always complete it by CO2 and bicarb. So the next question is the pH. Then you need to see what is the abnormality caused by. Either respiratory abnormality, metabolic abnormality. So just look at CO2 and you can tell. In respiratory disorders, the pH and CO2 will change in opposite directions. If pH drops, you need to have high CO2, because high CO2 only will cause acidemia. Low CO2 will cause alkalemia. So they will move in opposite directions in respiratory disorders. In metabolic disorders, it is a compensation. Like in metabolic acidosis, the body will try to compensate by decreasing CO2. So pH is low, CO2 should be low. They the same direction, that is metabolic issue. If pH goes up, the body will build up the CO2 in case of metabolic alkalosis to compensate for that. So the PCO2 and pH will change in the same direction. Just see pH and CO2 and you can tell what is the problem. If pH and CO2 are moving in opposite direction, that is respiratory pathology. If pH and CO2 is moving in same direction, it is metabolic pathology. That's all. By just seeing these two values, you can easily tell what is the primary pathology here. And sometimes you can have mixed disorders. It's not only purely metabolic, purely respiratory. You can have a combination of metabolic and respiratory. And for respiratory illnesses, you have metabolic compensations. And for metabolic illnesses, we have respiratory compensation. So just look at this. You have pH here, pH. So pH, you just start with the pH, you look for pH is low or high. So pH is low, you tell it's acidemia. Then you need to look for CO2 and bicarb. If you have high CO2, what is the pathology here? Child is acidemic and having high CO2. So what is the pathology? Is it metabolic or respiratory? pH and CO2 are moving in opposite direction. Yeah, they're moving in opposite direction, so it is respiratory. Because I not given the low CO2 here, so I give low bicarb directly here. So you see the bicarb is low, it tells it is metabolic. So in acidemia, you need to have either high CO2 or low bicarb. That's all. It's a two combination you should have. If it is high CO2, it is respiratory pathology. If you have low bicarb, it's metabolic pathology. Same explains with alkalemia. In alkalemia, you need to have low CO2 or you should have high bicarb. If high bicarb is metabolic alkalosis and low CO2 is there, it is respiratory alkalosis. But body will try to compensate for this. This is a primary process. There is something happening in the body so that you are getting some changes in the pH. Body will try to compensate for that. So in case of respiratory acidosis, the kidneys try to conserve the bicarb. So it will go up on the bicarb to compensate for the pH, to bring it towards the normal. It's not always going to become the normal, but it's always try to bring it closer to the normal. So if you have high CO2 to some issue like asthma or pneumonia, the body will try to compensate it by increasing the absorption of bicarb from the kidneys, try to conserve it, pushing out more of H plus from the kidneys. So somehow they'll try to compensate for the respiratory acidosis. Similarly, for metabolic acidosis, you will hyperventilate to wash out the CO2 and compensate for that. So these are the compensation. So you have primary pathology, you have opposite metabolic compensation. So that's why many times your body will try to compensate the pH towards normal. So the next important thing is you need to see whether the compensation for the primary disturbance is appropriate or not. So usually the compensation will never reach the pH to normal, but sometimes it can be possible. If pH returns to normal, you call it as fully compensated condition. If pH doesn't return to normal, you can call it as uncompensated or partially compensated, depending on many textbooks, many things will use 3 different things, but I prefer to choose only 2 things. If pH is normal, call it as fully compensated. If pH doesn't return normal, you call it as uncompensated, is enough. You want to call it partially compensated, fine. Any name, but it's compensated, uncompensated, that is enough. If you observe the compensation is not as the expected compensation, then it's likely that there's more on other pathology as well. So what does this mean? We'll see in the next slide. So just remember that if you don't meet the expected compensation, then you need to think about there is an add-on other pathology as well. So this is what the body will try to compensate. So your CO2 and bicarb will move in opposite direction to compensate for the pH, to bring it back to normal. And these are the formulas you need to learn or you need to stick with you. No need to by heart all these things. At least you need to by heart is metabolic acidosis one. This is a simple formula. So we'll see the examples. So just remember this one formula here, metabolic acidosis formula. So you need to calculate the expected PaCO2. This is the expected PaCO2. This is formulas all for what is the expected value for that bicarb or CO2. In metabolic acidosis, so you need to calculate the expected CO2. So it is 1.5 into bicarb. So if bicarb, say bicarb of 16, what is the expected PaCO2? Can someone calculate and tell me? So 1.5 into 16 plus 8 plus or minus 2. So your expected CO2 should be in that range.
30 to 34.
Yeah, 30?
30 to 34.
Yeah. So now you need to go back and see what is the CO2 of CO2 in the ABG. If it is in between 30 to 34, the compensation is adequate. There is no other respiratory etiology here. It's a metabolic acidosis. You are looking for any respiratory compromise also here. Whether respiratory alkalosis is there, respiratory acidosis is there extra. If your CO2 is in between these two numbers, 30 and 34, there is no respiratory pathology. That doesn't mean your pH will be normal. If CO2 is in between 30 and 34, that doesn't mean that your pH will be normal. pH doesn't become normal always, even if your body is trying to compensate by washing out CO2. So don't think that these two are too different. If pH is normal, that is fully compensated. Not normal, uncompensated, that's all. You stop it there. Then you need to look for compensation, whether the compensation is adequate or not. If CO2 is in the normal range of expected, then it is adequately compensated. There is no respiratory add-on respiratory pathology. Add-on, I'm what I say is add-on. If it is not in between the expected value, you can have respiratory alkalosis or respiratory acidosis. We'll see the examples in the next slide. So respiratory acidosis, acute one, it's like delta change in PaCO2 by 10. You can have a correction factor of plus or minus 3. And chronic respiratory, you need to multiply it by 3.5. Alkalosis, you by delta bicarb into 0.7 plus 40 of CO2, you need to add here. That is what your thing come here. In acute respiratory alkalosis, it's multiplication of 2. And chronic respiratory multiplication of 5. Sometimes you can go up to 7, but remember practical purposes. Acute respiratory is 1, chronic it is 4. Acute respiratory alkalosis it is 2, chronic it is 5. That's all. 1, 4, 2, 5. You remember this. And these two formulas for metabolic acidosis and alkalosis. You don't need to by heart all these things. You can stick it with you. And what I'm going to ask you is how to apply this in the ABG. So interpret and tell me what is this for. If you're able to tell this, you understand the concept of compensation very well. Already we calculated what is the expected CO2 here. Expected CO2 is 30 and 34. It should be between 30 and 34. So based on that, you need to interpret all these things. Compensated metabolic acidosis. Okay. All agree with that? Yeah, I'll give 2 minutes time. All please go through. The expected CO2 here is 34. So no need to calculate and waste your time. So you can answer. Put all 4 in the same. Don't give individual answers. Put all 4, 1, 2, 3, 4 like that in the same message. So it will be easier for me to interpret. All of us to try. If you don't try, you won't get it. Compensated. What compensated and compensated mentioned fully. So what is the main primary metabolic disorder? Primary disorder hit metabolic or respiratory, whether acidosis or alkalosis. So that we need to mention here. Mixed also you need to elaborate. What is that mixed? Whether it's respiratory acidosis or respiratory alkalosis. Add on one. I know everyone knows it's metabolic acidosis. So it's I given only the same thing in all 4P thing. So if you want to add mixed, you need to tell what is the other problem with the respiration, whether respiratory acidosis or respiratory alkalosis. Yeah, 1 and 2, everyone is telling correctly. Yeah, 3 and 4, I'm not able to get. It's not that complicated. I give very simple. No need to calculate also. Yeah, mixed metabolic acidosis, respiratory acidosis, fine. 4th one, mixed metabolic acid, respiratory alkalosis. Yeah. I think everyone finished. Or you people want some time? I got the answers. If you want some more time, I can give 1 or 2 minutes extra. I think the 3 and 4 will be confusing you people. 1 and 2, everyone is answering straightforward. 3 and 4, it is little extra. You need to understand these things. Shakti, you got your answer now? You want me to explain? Yeah, we'll start with the first only. Directly, we don't go to 3 and 4. We'll start with the first. And you people have to speak with me. You need to open your mics and talk first. So then only I can understand how much you are with me. So what is the pH here? The people who don't understand 3 and 4, they have to talk. Then only they can understand 3 and 4. The people who understand 3 and 4 don't talk. Please keep silent. pH is normal. So what we have to see here? CO2 and bicarb. So PCO2 is, what is the PCO2 here?
Slice.
PCO2 is 30. So what is the pH you expect here?
Increase.
You need to get an high pH, alkalotic pH, but it is not alkalotic. So you need to check for the bicarb. The bicarb is 16. So it is
Metabolic acidosis.
moving towards metabolic acidosis, and it is getting compensated by your respiratory alkalosis. That's what I will. The pH is around 7.45, 46 or 47, then I will be thinking that it's mainly respiratory problem. But pH is towards acidotic side here, and what is causing acidotic side here is bicarb. So it is a metabolic acidosis which is getting compensated by CO2. The compensation is full. So the first thing is it is fully compensated metabolic acidosis. Is it clear?
Yes.
Same thing. Second thing, your pH is 7.33. And one more thing, you need to calculate here what is the expected CO2. Expected CO2 here is 30, 34. Is it in the range? It is out of the range.
Within range.
Within range means there is no add-on respiratory pathology here. Agree? PCO2 is within the range, and it is a metabolic acidosis which is fully compensated. So it is purely uncompensated metabolic acidosis. Then move on to second thing. What is the pH here?
Is acidic.
Acidemia. So it is compensated, uncompensated.
Partially compensated metabolic.
It is partially compensated, uncompensated. It's fine for me. It's a metabolic problem because CO2 is low and bicarb is low. So it is mainly metabolic problem, not the respiratory problem. And CO2 is within the range, not in the range, expected range. It is in the expected range and not in the expected range.
Expected.
So there is no add-on respiratory problem here. So it is uncompensated or partially compensated metabolic acidosis. Is it clear? Clear. Can we move on?
Yes.
Then you see what is the pH here, third one?
Acidemia.
Acidemia, exactly. So we think bicarb is the main pathology here because CO2 is within normal range. CO2 is 39. 39 is normal, right? I'm not talking about expected range. I'm talking about normal range. If CO2 is normal, your pH should not drop like this. So the main pathology here is not respiratory, it is
Metabolic.
metabolic. Everyone agree? Everyone following me here? Because
Yes.
CO2 is in the normal range of what we think normal. Not for this particular patient. CO2 is normal, it will not cause drop in pH, so it is not the respiratory pathology, primary respiratory pathology here. It's mainly the metabolic pathology. But you are checking what is the expected CO2 for this bicarb.
Around 34, but it's more.
34 is the cutoff. So it is more. The more means
Respiratory acidosis.
exactly. Even though PCO2 is normal here, don't think that there is a respiratory problem here. There's a respiratory problem. If there is no respiratory problem, your CO2 should be in the range of 30 to 34. Got my point? What I'm talking?
Yes.
Is other option here. If CO2 is fully compensating with the same bicarb, your pH will be normal. If it's not that much compensating, your pH will be little lower. But here it is opposite direction. It is not compensating, it is moving towards the respiratory acidosis side. That way it is dropped further. So for this bicarb, the body is trying to maintain on the lower CO2 side. If it's not able to maintain the lower CO2 side, means that is there's a problem with the respiratory system as well. There is a respiratory acidosis as well. There should be some pneumonia. Because of the pneumonia, child might not be metabolic acidosis. So it is a mixed pathology. Main pathology is metabolic acidosis with respiratory acidosis as well. Is it clear? The CO2 is out of the range. CO2 is higher than what you expected. Anything higher than what you expected is acidosis. And coming to 4, your pH is normal, but still your bicarb is low. And your CO2 target here is 30, 34. But what happened to CO2 here? It's dropped further. Any CO2 moving lower than the expected is
Alkalosis, respiratory alkalosis.
Respiratory alkalosis. Because of metabolic acidosis and respiratory alkalosis, your pH becomes completely normal. It's moving towards alkalotic side here. There are two main pathologies here. It's mainly metabolic acidosis and also respiratory alkalosis. Is it clear? Are any doubts? So first thing is compensated metabolic acidosis. Second thing is uncompensated metabolic acidosis. Third thing is mixed. Because of CO2 is higher than the expected, it's respiratory acidosis. CO2 is lower than the expected, so it is respiratory alkalosis. That's all. The main pathology here is metabolic acidosis, and you're looking for the compensation. You're looking for the compensation, fully compensated or uncompensated. And along with that, you are seeing the expected CO2 for this bicarb. The expected CO2 for this bicarb is 30, 34. In the third example, the CO2 is higher than the expected, so it is respiratory acidosis. It's lower than the expected, so it is alkalosis. That's all. Is it clear for everyone?
Sir, actually you said that if there is metabolic acidosis, PCO2 is in the normal range. That is what we expected is 30 to 34. But even though it is in that range, if pH is low, then it can be compensated or non-compensated. We can say it cannot be in the normal range. You said no.
Don't confuse yourself. Compensated, uncompensated is based on pH, not CO2, not bicarb. Just
Okay.
it's only pH. If pH is the normal range, it is compensated. If pH is not in the normal range, it is uncompensated, partially. That's all. You stop it there. You don't mix up with the CO2 again.
Okay.
Then you need to look after any add-on respiratory or metabolic problem. You are not thinking of only one problem here. If you're thinking of add-on problems, then you need to calculate what is the expected value. If you have metabolic acidosis, you need to look for what is expected CO2. If you have respiratory problem, you need to look for what is expected bicarb.
Okay. Okay.
If they are in the range, then there is no add-on respiratory or metabolic problem. If they are not in the range, there is an add-on respiratory or metabolic problem depending on what direction the pH and the element is moving.
Okay.
Clear?
Okay.
Compensation, uncompensation is only based on pH. Never ever get confused based on our calculated values. Calculated values will tell that is there an add-on problem. That's all. It's not going to talk about it's compensating and uncompensating. It will tell is an add-on respiratory and metabolic problem. That's all.
Okay.
Can we move on? How to decide which is primary? You need to think about pH, which direction pH, which direction the first example. You have both. You see here, CO2 is 30. So you are talking about fourth example or first example. I'll go to fourth example because it's clear for me. So here you cannot tell which is primary. No need to talk about primary here. If you have two components, you treat two components. You cannot limit it to one component, which is primary here. You don't need to think about what is primary. In mixed disorders, you don't need to think what is primary, what is secondary here. There are two disorders, that's all. You need to address both disorders. In 1 and 2 exams, it's clear. It is not respiratory pathology, it's only metabolic pathology. In mixed, there's no need to think about what is primary, what is secondary. There's no primary, secondary here. It is both. You have both disorders. You need to address both disorders. I hope I'm clear what I'm talking. In mixed pathologies, don't confuse yourself which is primary, which is secondary. There's no primary, secondary. Both disorders are there. You have two different disorders here. Don't confuse with that. Secondary is for compensation. If you have extra problem, it's not compensation. It is disorder. You need to address that disorder. So next question is, if you have metabolic acidosis in mixed disorder based on history, yeah, that's what I'm telling. You need to address. You take history. You calculate the pH change. A lot of things that I don't want to confuse you here. No. It's not telling. If you have two disorders, you need to address two disorders. That's all. Which is more important? Which is secondary important? That's up to you. So I don't want. Yeah.
Sir, one query. So sometimes they are telling delta ratio to find out which is
Yeah.
primary.
I'll come. That I don't want to confuse you. That's why I just want to touch here. So you want to tell is an acute or chronic in respiratory, you need to see the delta pH change. It's only for respiratory disorders. So I'm not included in this because I don't want to confuse you people. If you understand this much for today's class is enough. If you want, you can share the articles. I'll talk in the group individually. So I won't talk about delta pH change in calculation of acute or chronic change. Easily you can figure it from history. If you take a good history in respiratory pathology, you can easily figure it out which is acute or chronic problem. Acute or chronic problem is mainly for respiratory, not for metabolic. It's not going to make any difference for me in metabolic. It's acute or chronic because my compensation formulas never included acute or chronic there. You can see here. It's only for respiratory, it's acute and chronic. For metabolic, it's simple. It's metabolic acidosis, metabolic alkalosis, that's all. Whereas chronic metabolic acidosis, chronic metabolic, it doesn't make any difference for me. That's what I'm telling. Don't get confused yourself. And respiratory, easily you can figure from history. Whether how many days the child is having respiratory distress, how many having, we can easily get from history. Then why you want to calculate from the ABG? So don't strain your brains too much. That's what I'm telling. Theoretically, you can deal with anything. I'm talking about the practicals here. I don't want theory here. So you go back and read what you want. What is the pH change? Can tell it acute or chronic. Easily you can figure out from history. And what is primary, what is secondary. There's no primary, secondary in mixed disorders. Both are disorders. You are confusing between primary disorder with secondary compensation. Don't get confused there. In these two examples, these first two examples, you have a secondary respiratory alkalosis which is compensating. That is not a disorder. That is normal. That is expected. You see here, what is CO2 here? CO2 is 1333. 1333, what it means? Is respiratory alkalosis or normal CO2 disease? Your CO2 is 1333 here. It is normal CO2 or it is respiratory alkalosis?
Respiratory alkalosis.
But you are not calling it as add-on respiratory alkalosis here. Why?
Because the compensation
Because of
calculation.
the compensation. You don't talk compensation as secondary pathology. It is not secondary pathology. It is a normal pathology, normal physiology of the body to compensate. You have metabolic acidosis, for that your body is trying to compensate. So you don't call it as a disorder. That's what I'm telling you. Don't call it as respiratory alkalosis. Many times you confuse with that. You call it as respiratory alkalosis. No, it's not respiratory alkalosis. It's just metabolic acidosis. And it's a compensation from the respiratory system. That's all. You talk like that. Then you don't get confused. It's metabolic acidosis getting compensated by respiratory system. That's all. Don't call it as respiratory alkalosis, which is compensating metabolic acidosis. That is not true. Then you move on to third and fourth. Here, that's even the fourth one, you see, the fourth one, the PCO2 is very low. Even it's trying to compensate, but it's not in the range of compensation. It's already crossed the compensation range. So that's why it is an add-on respiratory alkalosis. Whether it's acute respiratory alkalosis or chronic, I don't want to bother. I don't want to confuse you people here. You go back, take history, and decide whether it's acute or chronic. Is it clear? In 1, 2, 3, 1, 2, 4 examples, you have CO2 on lower side. But in 1 and 2, you are not adding respiratory alkalosis in the disorder. You are just telling it's metabolic acidosis, compensated, uncompensated. But in fourth one, you are adding, there is an add-on respiratory alkalosis. So here two pathology is there. It is metabolic acidosis, respiratory alkalosis, that's all. What is primary, there is no primary, secondary in fourth one. That's what I'm telling. You can call it severity, which is more severe. You talk like that. Don't talk primary and secondary in fourth one. Primary and secondary is in 1 and 2. Primary is metabolic acidosis. Secondary is respiratory compensation by creating alkalosis. That's all. In fourth one, respiratory compensation is there, but it's overcompensated. So there is a respiratory alkalosis as well. So you need to address two things here: metabolic acidosis, respiratory alkalosis. Which is primary, secondary, nothing. There's no primary, secondary here. More, which is severe. I need to address that. Okay, fine. Metabolic acidosis is severe, respiratory alkalosis is severe. You talk like that. Don't talk primary and secondary in fourth example and third example. I hope I am clear for everyone. Any doubts further here? In mixed disorders, don't talk about what is primary, what is secondary. There's no primary. They both are disorders. That one point people have to get here. Only in 1 and 2 examples you can talk. Primary is metabolic acidosis. Secondary is respiratory compensation. Respiratory compensation. Don't talk when alcohol is there. It is compensation. If you talk like this, you won't get confused. You don't correct CO2 here, right? If child was on ventilator, you don't have to try to normalize the CO2 here. But in 4th example, if you ventilate, you are doing your child is on ventilator and CO2 is dropping this much, you try to increase CO2 to at least 30 to 34. Right? You need to address that. In 1 and 2, you don't need to address. In 3, you need to address the respiratory. If child is on ventilator, you need to correct the CO2 because you cannot stop CO2 saying 39. I cannot drop the CO2 further. You need to drop. You need to correct it also. If this child is on ventilator with a pH of 7.26 and PCO of 39, I am going to increase the rate. Definitely, I'm going to increase the rate. I will bring back the CO to 30, 34, in between 30, 34, so that my pH will be little higher side. And if this 4th condition, the child is on ventilator, I'm going to decrease the rate to bring back the CO2 to 30, 34. I hope I'm clear. I need to address both things in mixed problems. I cannot address only one thing. But in 1st and 2 examples, I will address only metabolic problem. I will not address respiratory problem at all. I will accept this CO2. That's the major difference between these 4 examples I given. In mixed disorders, you need to address both. In single problem disorders, you need to address only one. It depends on PAP or rate. It depends on what volumes you are on. It's entirely deviating. I'm not going to talk here. We can talk later. You can message me personally. I'm just giving an example. That's all. So I'm going to move on. If you have any doubts further, you can contact me directly. So next thing is metabolic acidosis. In any metabolic acidosis, you need to calculate one thing. What is anion gap? So anion gap is nothing but sodium minus your chloride and bicarb. So main anion is sodium, cation is sodium, and anion is chloride and bicarb. The normal is 12 plus or minus 2, and you need to correct this anion gap for hypoalbuminemia. Every 1 gram drop in albumin, you need to lower the anion gap by 2.5. So what is anion gap here? Can you calculate and tell me what is anion gap here? So based on anion gap, you need to classify metabolic acidosis as high anion gap or normal anion gap. So one is anion gap is 24, it is high or normal anion gap?
High anion.
2. Second example. So second example, what is the anion gap here? 12. So it is normal anion gap. Okay, I think it's very simple. So we'll move on. So what is the main principle between anion gap calculation? You feel that anion gap, that means there is more cations than anions in the body. That's why you're calculating anion gap. So what do you meant by anion gap of 12? Whether the 12 difference is between the cations and anions in the body? Do you feel like that? There is 12 difference in the anions and cations in the body? Always? The main principle of anion gap calculation is ionic equilibrium. Always till your death, cations will be equal to anions. There's no doubt. Whatever condition, whatever pathology, whatever underlying problem you have, always body will have equal number of cations to anions. If they got disrupted, your life will not be there. Until the last moment of your life, your cations will be equal to anions. That is called ionic equilibrium. So what you are telling? You are telling atoms is equal to anions, then you are telling anion gap. Yes, the anion gap is what you don't measure. You can see here. So these are the unmeasured cations. Unmeasured cations are calcium, magnesium, potassium. Your major chunk is sodium, so that is taking part. And you see here the chloride and bicarb is only 60% of what unmeasured anions is there. Total anions are there. So you have a difference of this much amount of unmeasured anions. This difference is called anion gap. It's just unmeasured because you're not able to measure. What are they? Phosphorus, proteins. So these are the things you're not going to measure routinely. So for that, to compensate that, you are just labeling them as anion gap. And what is more important is whether this gap is increasing or not based on the acid-base disorders, mainly metabolic disorders. You are just seeing whether this gap is getting increased or not. That's all. If the gap is getting increased, that means you have an extra unmeasured anion here. Extra unmeasured anion here. That's why you call it as high anion gap. What are the examples of high anion gap metabolic acidosis? Can you give 2 examples?
Diabetic ketoacidosis.
Exactly. And lactic acidosis. So you don't going to routinely measure lactate and ketones. So that increase in anion gap tells that there is something else in the body, some extra anion in the body, that is lactate and ketones. If it's getting normal, you start treating DKA, you have high anion gap of 30 at the starting. And slowly with the method, with insulin and treatment, the anion gap is coming down. It's becoming towards 12. What does it mean? From 30 anion gap, it's coming towards 12. What does it mean in DKA management? Wait. You started DKA management at the anion gap of 30, and with your management, it is coming towards 12. That means your ketones production is stopped. Your ketones are normalized. That's all. You don't need to measure ketones also. If you don't have facility for measuring ketones, the ketones are stopped. Same thing in shock. In shock patient, your anion gap is getting normalized. That means your lactate production is stopped. That's all. So that's why you need to keep checking the anion gap, keep calculating the anion gap to know whether the pathology is resolved or not, even if you don't measure them directly. So always remember this one point, ionic equilibrium. Then if you have low bicarb, how you get normal anion gap then? Which is compensating here? In high anion gap, you have low bicarb because you're not able to measure the anion gap. So you are getting high anion gap. Yeah. Chloride. If you have diarrhea and bicarb is getting lost in the diarrhea fluid, the body will try to conserve the chloride more because to maintain ionic equilibrium. In lactic acidemia and ketone acidemia, already it's getting compensated. You don't need to compensate by increasing chloride. The extra lactate, extra ketone, what is there, it is already compensating for the ionic equilibrium. So that's why your gap will increase because chloride is not getting increased. Only bicarb is getting decreased, and you measure only bicarb and chloride, so your gap will increase. But in case of diarrhea, there is no extra add-on anion. That's why if you have a bicarb loss, the body will try to increase the chloride to compensate for the ionic equilibrium. You're going to measure chloride. So the drop in CO2, the rise in chloride will compensate each other. So anion gap will be normal. So that is the principle behind anion gap. You need to calculate anion gap to know whether this is an add-on extra anions like high anion gap metabolic acidosis to know what is the reason for metabolic acidosis. So we'll see the example so we don't, And finally, if it's high anion gap metabolic acidosis, you need to see the delta ratio. So what is this delta ratio? It is a change in anion gap by change in bicarbonate. That's all. So in the previous example, the first example, anion gap, the change in anion gap is 12. That means 24 minus 12. The normal is 12. The anion gap is 24. So the change is 12. And what is the bicarb there? Bicarb is 12. So change in bicarb is 24 minus 12. So 12 by 12, the ratio is 1. I'm talking about this example. The first example where the anion gap is 24. The change in anion gap is 12. The change in bicarb is 12. The ratio is 1. So if the ratio is 1, it is pure high anion gap metabolic acidosis. If the ratio is less, the change in anion gap is less than change in bicarbonate. That means there is an add-on normal anion gap acidosis. The change in anion gap is less. That means there is an add-on normal anion gap metabolic acidosis. If the change in anion gap is more, then there is a add-on metabolic alkalosis. We'll see the example so that you can understand. Just remember change in anion gap by change in bicarbonate. If it is between 0.8 to 1.2, it is just pure anion gap metabolic acidosis. If it is less than 0.8, it is add-on normal anion gap acidosis. It's more than 1.2, it is add-on metabolic alkalosis. Just to go through 3 examples, then you know. You need to answer quickly. We are running short of time. Already first example, you know. So calculate the anion gap, calculate the change, and tell.
First one is high anion gap.
It's pure or mixed?
Pure, sir.
Yeah, fine. Second one.
Second is mixed, sir.
Not mixed.
Mixed high and normal anion gap is good.
Exactly. Yes. It's a mixed. You can see here. See the chloride level went up here. Same for same bicarb, the chloride level went up. When chloride level went up, in what condition is a high anion gap or normal anion gap, chloride level will go up. You don't need to calculate also. Just you can see and tell what is happening here.
Normal anion.
That's all. The chloride level goes up. That means there is an add-on normal anion gap. So third example. Compare the 1 and 3 here. Chloride is same, but your bicarb gone up. Bicarb gone up means what conditions do we have bicarb high?
Metabolic alkalosis.
That's all. You don't need to, that's what I'm telling. If you know the concept, what is happening, you don't need to do the calculations regularly. That's what I will do. So, for example, the same example I will give. I have a DKA patient. pH of 7.1 with a bicarb of 12 and 104. See here, this is the first thing. DKA patient, and this is the initial values. So what is the reason here in DKA for these initial values? Acidosis is due to what? DKA child with pH of 7.1. This is the values. Sodium, bicarbonate, chloride, the first one.
Ketones are increasing.
It's because of the pure ketones, right? And after 12 hours of the treatment, this is the values. pH is still 7.1. pH is still 7.1, but these are the values.
Compensating by chloride.
Why it is compensating with chloride? What is the problem here? Why pH is not improving? Why bicarb is not improving? Even your insulin, fluids, ketones are coming down. Why the pH is not improving? Why the bicarb is not improving?
Mixed component.
Why chloride is increasing? Hyperchloremic metabolic acidosis, because you're giving so much of soda means NaCl, your chloride levels are going up. That is not allowing the bicarb to come up. That is called hyperchloremic metabolic acidosis. So when you just keep looking at anion gap, it will give the clue for you. whether is an add-on metabolic, other metabolic problem as well. It's the only pure high end of metabolic acidosis like ketone acidosis, or the ketones are getting down and still my pH is not improving, my bicarb is not improving, means there is some add-on pathology as well. That add-on pathology is hyperchloremic metabolic acidosis in case of DKA because of your excess NaCl. So you need to change over to RL or you need to change over to plasma-lite, which is balance of solutions. Is it clear? That's why the delta ratio is important, especially in DKA management. I think if people got what I'm talking.
Yes.
Yeah. So with these steps, so the first thing is pure iron gap, second thing is mixed, third thing is add-on metabolic alkalosis. So I'll just rush up to the technical errors. The main technical error is excess heparin. So don't leave the heparin in the syringe. You need to flush it. You need to make it 0. So if heparin is there, it will decrease the pH because it's acid. It will decrease the pH and it decreases CO2. So never ever leave heparin in the syringe, and never ever use syringe more than 3 cc. Ideally 1 cc, 2 cc also fine, but never use syringe more than 3 cc. And most important thing is you should not get the air bubbles into the syringe. You need to flush it out as early as possible. If you, because the PO2 in the room air is 150, CO2 is 0, almost near 0. So it can increase the PO2, it can decrease CO2 in the real values. So you need to seal them very much immediately. No need to expose them to air at all. So no air bubbles, don't expose to air, seal them properly. And if you expose it to air, you need to flush it out the air immediately, because it is going to alter the O2 and PCO2. The most important thing is if you not have facility in your hospital, you're going to transport the ABG to other hospital. You need to be in ice pack, because if you don't keep it in ice pack, it's going to change. See the in 10 minutes, the CO2 can change by 1. The pH can change by 0.01. So if it's going to transport of 1 hour or 1.5 hours, you see how much change is going to happen. So always try to maintain it cold chain. When you're sending to other hospital or other place, you need to maintain it in the cold chain. This cold chain is very important for transport. And finally, treat the patient, not the ABG. I see many times you're treating the ABGs. So don't treat the ABG, treat the patient. You go back, take the history, detailed examination. So then only decide whether you need to treat this ABG or not. Just don't look at the value. It will be very important to look at the ABG and treat in serious emergencies like severe metabolic acidosis, severe shock, where pH is 6.9. Like child came to you with like septic shock, severe septic end stage septic shock, very late stage presented, and pH is 6.9. Child had severe metabolic acidosis. Your inotropes are not working. So then you need to target and you need to treat the base deficit. That are the only examples, conditions where you need to treat the ABG as early as possible. But in DKA and all, even if it's 6.9 pH, you don't treat them. So you need to go take history, what is the treatment, whether the DKA or not. Then you're going to treat the ABG. Understood? So if 6.9 pH, don't rush and give bicarb. You need to see what is the cause for bicarb, low bicarb, whether it is DKA, whether it is some other thing, whether it is IEM. So then only you're going to treat this. That's what I'm telling. Except in an emergency, don't treat ABG. You need to analyze what is the reason for the ABG. Then only you need to treat. So with that, I'm going to end this session. And if you have any doubts, you can contact me. How to differentiate lactic acidosis? No, we cannot differentiate until unless you have measurements of lactate or ketones. So we have the facility for lactic acid measurement in our ABG machine. And you can check the ketones with the blood glucometer, blood ketometer, or urine. So until unless you have that facility, you cannot differentiate. You can just tell that it is high and metabolic acidosis, and at least you need to have lactate for differentiation. Without lactate, you cannot differentiate. Or you need to take a good history, and you have high sugars, you need to suspect ketoacidosis. Until unless you have that strong history, you cannot differentiate. Based on ABG, you cannot differentiate. You need to have history and lactic and ketone measurements.
So my one query is in tertiary center where there is no facility for ABG, how can assume that this may be ABG disorder?
No. I not got your question. You don't have ABG machine, so
Yes, how in serious patient, how you can assume that this patient,
you need to assume that's all. Any sick patient will have metabolic acidosis. Any shock patient will have metabolic acidosis. You need to see the breathing. Acidotic breathing is there, it's acidosis, that's all.
thank you, sir.
If you don't have ABG machine, then you need to play the guard, that's all. To get it early. There's a lot of handheld machines are available. It will be very cheaper. At least they'll give basic readings, bicarb, CO2, that much is enough. No need for high-fi things. I strongly suggest all the centers which is going to take sick patients, you need to have ABG. Without ABG, you are blind. Either you assume that the child is having metabolic acidosis, correct it and refer to higher center, then keeping with you. If you want to keep them with you, buy a ABG machine, simpler one, not the hi-fi machines what we are using. You can just get a simpler one. But without ABG, you should not manage sick children. That's what I can say.
Yes. And sir, in ABG criteria to intubate, that is how much practically applicable?
Which one?
ABG criteria to intubate the patient, is it practically?
No. ABG will not decide to intubate. Intubation is based on clinical parameters, that's all.
Thank you, sir.
ABG tells you that once you intubated, it can tell you how much is the settings you need to keep. Your CO2, PO2, based on that, you can adjust your settings. That's all. Decision on intubation is not based on ABG, it's based on your clinical features, clinical things like your vitals, your oxygen levels. So DKA shock, both ketoacidosis and lactic acidosis, yes, fine. So what management is going to be different there? It doesn't going to change any of your management in management of DKA with shock. Shock, you treat the shock. DKA, you treat the DKA, that's all. ABG is not going to make any difference there.
Thanks.
Base excess important in ABG. Yes, in IMs, definitely important. You need to calculate what is the bicarb you need to give based on base excess. Sorry, base deficit actually. Base excess is more or less, base excess is seen in alkalosis, base deficit is seen in acidosis. It's just what is the difference between actual bicarb and standard bicarb and the normal bicarb, that's all. You can calculate yourself. You don't need to calculate, no need to see it there. If you have standard bicarb, you just subtract it from the normal, like you say, normal bicarb is 24. If you have bicarb of 16, the base deficit there is 8. That's all. If they give that directly, you can do that. It's mainly for your calculations of how much bicarb to be given. Otherwise, there's no use of them. Mainly in IM patients to calculate what the bicarb dose to be administered. What is the ventilator settings for respiratory alkalosis? More tidal volume, more rate. Respiratory alkalosis is less tidal volume and less rate. Its minute ventilation. CO2 is inversely proportional to minute ventilation. If high CO2, you increase the minute ventilation. Low CO2, you decrease the minute ventilation. They'll run in opposite direction. Any mode, you need to control the tidal volume. If you have high 6 ml per tidal volume, you decrease to 5 by decreasing the pressure. Then you decrease the rate, that's all. Yeah, any more questions you can put in the group. I will answer in the group. If no further questions, major questions, we will end the session. Go need to practice. I'm going to put the ABGs in the group, so you cannot practice. Yes, you can change tidal volume and per control ventilation. That is what I'm telling you. Adjust the PIP to decrease the tidal volume. It's indirect change in tidal volume. It's not direct change. Your PIP controls the tidal volume. You drop the tidal PIP, it will decrease the tidal volume. That's the. Okay, thank you.